Hello, this is Dr. Stanley Kim again. I will discuss prostate cancer treatment now. With a continuous improvement in drug developments and technology, many patients with prostate cancer enjoys long-term survival, even with a metastatic disease. Let's discuss more in detail, and thank you so much.
The treatment decision is based on risk stratification. When the patients have low risk, then they may not need to have an immediate treatment. Or when they have a high risk, then we like to treat more aggressively. The treatment options for prostate cancer patients are active surveillance without treatment, just observation with a close monitoring, or surgery, radiation therapy, hormone therapy, or other treatment for localized prostate cancer, including cryotherapy, high-intensity focused ultrasound, or focal laser therapy. Active surveillance is just observation without immediate therapy. It's indicated for very low or low-risk patients. Patients need to have a repeat biopsy every usually 2 years. If there is no change, then less frequently, using prostate MRI scan. And the PSA is done every 3 to 6 months, and the digital rectal exam every year. When the patients progress during surveillance, then they have to have a definitive therapy. Some patients with the favorable intermediate risk group may choose active surveillance. Robotic-assisted radical prostatectomy is most commonly done nowadays. And it may benefit younger or fit patients because older patients may experience more complication from this surgery. When you compare the surgery with the radiation therapy, the overall survival rate is compatible, so either one is fine. Radical prostatectomy indicated in all kind of patients, but the low-risk patients do not need to have a pelvic lymph node dissection when surgery is done. Complications include the impotence, that's most important. A frequent after surgery gradually improves, but eventually about 50% of patients will have a sexual dysfunction at 2 years. Bilateral nerve-sparing surgery will cause less impotence. We use the phosphatidyldehydrase inhibitors like a Viagra or Cialis with about 50% response rate. Urinary incontinence also seen in about 50% of patients, but gradually improved to 10 to 15% at 2 years. Pelvic muscle exercise sometimes help. Bladder neck or urethral strictures seen in 10% of patients. For external beam radiation therapy, new technology using IMRT and the IGRT radiation therapy are used. IMRT stands for intensity modulated radiation therapy. This technology targets the tumor very effectively, avoiding the damaging the normal tissue nearby. IGRT is image guided, so it's make it more precise. Indication is for the low risk, intermediate risk, and the high risk patients. For unfavorable intermediate risk and high risk patients, hormone therapy is combined. I will discuss later in this slide. Proton therapy is also used, but there is no real benefit over the standard IMRT or IGRT. Complications include the urinary incontinence, which is almost always resolved several weeks after radiation therapy. Sexual dysfunction is more prominent, occurring about 40% by 2 years, almost same rate as surgery. Sometimes patients develop diarrhea from radiation proctitis. Brachytherapy involves the radioactive seeds directly inserted into the prostate. Please look at this picture. This radioactive seeds, like iodine 125 or palladium 103, will be manually inserted into the prostate gland. So hundreds of the radioactive seeds will be placed. It's indicated for low-risk and the intermediate risk patients. For unfavorable intermediate risk patients, external beam radiation will be added after radiation, the brachytherapy. Complication includes the acute urinary obstruction if the prostate is large, because it can cause inflammation in the beginning, so causing more obstructive symptoms. But the sexual dysfunction or bile toxicity rates are similar to those of external beam radiation therapy. Hormone therapy is basically used for the metastatic prostate cancer, but is also combined with the external beam radiation therapy for unfavorable intermediate risk or high-risk patients. Androgens, including testosterone, stimulate prostate cancer cells, so reducing blood testosterone to the castration level less than 50 nanogram per ml shrinks prostate cancer in 90% of patients, although it doesn't cure prostate cancer. Testicles produce 95% of testosterone, and remaining 5% are produced by adrenal glands. Testosterone production in the testicles are stimulated by luteinizing hormone from the pituitary gland, which is stimulated by gonadotropin-releasing hormone from hypothalamus. Please look at these pictures. In the brain, in the hypothalamus, gonadotropin-releasing hormone is produced, which stimulates the pituitary gland to produce luteinizing hormone, LH. It is the luteinizing hormone, LH, that stimulates the testicles to produce testosterone, and this testosterone stimulates the prostate cancer cells to grow. And the 5% of testosterone are produced by adrenal glands. Then how to block the testosterone production? We can do that at the brain level using gonadotropin-releasing hormone agonist or antagonist. Gonadotropin-releasing hormone agonist initially stimulate pituitary gland to produce LH, luteinizing hormone, and consequently resulting in 200% increase in testosterone production for the first several weeks, which is called the testosterone flare effect. It's no good because testosterone stimulates the prostate cancer cells. So clinically, we use the anti-androgen with this gonadotropin-releasing hormone agonist to block the testosterone flare effects. Gradually, the pituitary gland is desensitized by repeated gonadotropin-releasing hormone agonist, finally stopping all testosterone production in the testicles. On the other hand, gonadotropin-releasing hormone antagonist doesn't cause testosterone flare effect, reducing testosterone level immediately. Lowering testosterone to the level of castration can be achieved by surgical orchiectomy, just remove the 2 testicles, or by medical castration using gonadotropin-releasing hormone agonist or antagonist. These are called androgen deprivation therapy. The drugs for androgen deprivation therapy include gonadotropin-releasing hormone agonist, which are leuprolide, leuprol injection, Zoladex injection. Gonadotropin-releasing hormone agonists include degarelix, Firmagon injection. Recently, FDA approved the Orgovix, which is the oral pill form of gonadotropin-releasing hormone antagonist. Side effects include hot flash, sexual dysfunction, weak bone, anemia, depression, and especially cardiovascular morbidity. So we have to be very careful when the patients have a cardiac disease. The most testosterone produced by testicles can be blocked by androgen deprivation therapy, but the remaining 5% also can be blocked by anti-androgens. First-generation anti-androgen, especially Apalutamide, Casodex, is still used to prevent the testosterone flare effects. But mostly now, we use the second-generation anti-androgens, enzalutamide, Xtandi, Apalutamide, Erleada, darolutamide, Nubeqa. And also, Abiraterone, Zytiga is also commonly used. The side effect is breast tenderness, swelling of the breast, decreased muscle mass or body hairs, decrease sexual dysfunction, but it's less severe than androgen deprivation therapy. Apalutamide, Zytiga, can cause the increased mineralocorticoid side effects, resulting in hypertension, hypokalemia. So patients need to use the Zytiga with the prednisone or dexamethasone. Enzalutamide, Xtandi, can cause seizures in about 1% of patients. So you have to be careful when patients have seizure disorders. Treatment for low-risk patients is usually active surveillance with just observation with close monitoring. But some may want to have a radical prostatectomy or radiation therapy to get it over once for all. Treatment for favorable intermediate risk patients include the radiotherapy without hormone therapy and the radical prostatectomy with a pelvic lymph node dissection. Active surveillance is an option for favorable intermediate risk patients. Treatment for unfavorable intermediate risk patients also include the radiation therapy and the radical prostatectomy with the pelvic lymph node dissection. When the patients receive the radiotherapy, especially external beam radiation, 4 to 6 months of androgen deprivation therapy starting 2 months before the radiation is recommended. For high and very high risk patients, usually external beam radiation therapy combined with the hormone therapy for 18 to 24 months is preferred. Sometimes brachytherapy boost will be added to the external beam radiation. But radical prostatectomy with the pelvic lymph node dissection is still an option. When the patients had a surgery, adjuvant radiation therapy is not standard treatment because there is no benefit when compared with the delayed or observation after the prostate surgery. Radiation and hormone therapy after surgery for high-risk patients is also controversial, but short-term hormone therapy may be okay. Biomarker assay tests such as Decipher may help to determine who need a radiation or hormone therapy after the surgery, but their use is not universally recommended yet. Pelvic lymph node metastasis can be found before definitive treatment or after surgery. Regular CT and the MRI is not very accurate, but the newly approved PSMA PET-CT scan is much better in detecting lymph node metastasis. Treatment options for clinically positive pelvic lymph node metastasis is usually external beam radiation therapy, including the whole pelvis, combined with 18 to 20 months of ADT. But the radical prostatectomy with extended pelvic lymph node dissection is an option. When the pelvic lymph node metastasis is found after radical prostatectomy, the management is somewhat controversial. Usually, we give radiation therapy with 20 to 46 months of ADT. But when the patients have favorable factors like a Gleason score 7 or below, or lymph node metastasis only 2 or less, then just observation without any radiation or ADT is an option. After definitive surgery or radiation therapy, about 30% of patients develop biochemical failure with a rising PSA without detectable obvious metastasis. Definition of biochemical failure is PSA goes up over 0.2 after radical prostatectomy, or after radiation therapy, PSA rise over 2 above the nadir PSA. How to treat those biochemical failure? If the patients had a prostatectomy previously, they can have salvage radiation therapy after the recurrence is proven by biopsy. After the radiation therapy, patients can have a salvage surgery, radical prostatectomy, or cryotherapy, brachytherapy, or high-intensity focused ultrasound. But many patients choose not to have this salvage treatment because of in fear of complication. So if the salvage therapy is not feasible, then we give hormone therapy. either early treatment or delayed treatments. The early hormone therapy improves the cancer-specific mortality, but not the overall survival, so either one is fine. If the disease is aggressive, PSA doubling time is less than 10 months or become resistant to ADT, then ADT in combination with the second-generation anti-androgens is indicated. Enzalutamide, apalutamide, darolutamide. During the ADT, bone health therapy like denosumab, Prolia 60 milligram every 6 months is indicated. Patients may develop obvious metastatic disease and still respond to the androgen deprivation therapy. It's called metastatic castration-sensitive prostate cancer. The treatment of choice is ADT combined with the second-generation anti-androgen. It prolongs the survival, especially for high-risk disease. For example, the PSA doubling time is 6 months or less. The drugs we use is Abiraterone, enzalutamide, apalutamide. We used to use the first-generation anti-androgen along with the combined with the ADT, but no longer recommended because of no benefit. But this first-generation anti-androgen, especially bicalutamide, Casodex, is still used to prevent the testosterone flare effect we discussed in the previous slides. ADT with the docetaxel chemotherapy is another option. It also prolongs the survival for patients with metastatic castration-sensitive prostate cancer. When the patient's bone metastasis, we recommend the zoledronic acid, Somida, 4 milligram IV every 12 weeks, or Exgiva 120 milligram every 4 weeks, along with the dental care, vitamin D, or calcium supplement. When the patients develop metastatic disease, do you give this hormone therapy immediately or later when they become symptomatic? Immediate ADT improves cancer-specific mortality, but not the overall survival. So it's not absolutely necessary to start the hormone therapy immediately. Hormone therapy means we give continuous ADT, but intermittent ADT is also another option. Patients with rising PSA may stop this hormone for 6 to 12 months when the PSA reaches the lowest level. When the PSA rises again over 10, then this ADT is resumed. It didn't show any inferior results in terms of overall survival when compared with the continuous ADT. However, this is mostly for the biochemical failure patients. When the patients have obvious metastatic disease, we're not 100% sure this intermittent ADT is still as good as continuous ADT. But recently, NCCN in 2020 recommends this intermittent ADT to be considered with a close monitoring. Interestingly, about 1/3 of patients continue to have a testosterone level less than 15 nanogram per ml even after this ADT was discontinued. When the patients have a metastatic disease, only like several called oligometastatic disease, patients may have a stereotactic radiotherapy or even surgical resection, so-called metastatectomy, because study shows it improves the ADT-free survival. When prostate cancer no longer responds to ADT, then we call it castration-resistant prostate cancer. Patients still can use second-generation anti-androgen, enzalutamide, apalutamide, darolutamide, or Abiraterone when they haven't received one of these. And we recommend a genetic test for deficient DNA mismatch repair genes and for deficient homologous recombination repair genes. When the tumor is deficient in DNA mismatch repair genes, then immunotherapy with pembrolizumab, brand name Keytruda, is an option. When the tumor is deficient in HRR homologous recombination repair genes, such as BRCA1, BRCA2 mutation, either somatic or germline, PARP inhibitors, olaparib or rucaparib is an option. If the cancer is aggressive, chemotherapy using docetaxel or cabazitaxel is recommended. For bone metastasis only, radium-223 radioisotope therapy can be considered. Sipuleucel T immunotherapy is also another option if the patient doesn't have any liver metastasis. Other miscellaneous drugs include ketoconazole, estrogen, megestrol, glucocorticoids. When the patient was on first-generation anti-androgen, and when you stop the anti-androgen, sometimes patients respond. It's called androgen withdrawal effect. Thank you for watching.